approach to neurodegenerative disorders. And I think as pediatricians, maybe you would more commonly see these disorders, or you would more commonly suspect these disorders. So we will be discussing about these disorders. And here the learning objectives are going to be that when do you suspect a neurodegenerative disorder? Trying to classify them, though a perfect classification is not there. And again, what are the clues in history and examination, and how to differentiate it from static insults, because a large number of patients are labeled, say, as cerebral palsy or HIE sequelae, and many of them would turn out to have a genetic cause also. The investigations, and again, we will be having a lot of case scenarios. So this is a definition of neurodegeneration in general. So neurodegeneration can be acquired also. It's not always genetic. And acquired neurodegeneration can be secondary to immunological causes, infections, trauma, so many things, right? So any of a group of hereditary and sporadic conditions which is characterized by progressive dysfunction, degeneration, and death of specific populations of neurons. And that's why these diseases are progressive. So this is an overall definition of neurodegeneration. I always keep this scenario, and these pictures I have taken from Shubha because it's a very typical case. This case, in fact, I use almost everywhere, which I took from her long back. So this is a child who was 2 years old, who was normal till 1 year of age, and then he had loss of motor milestones, which was progressive. There was no history of seizures, altered sensorium, vision, or hearing problems. A past and family history, one previous child had died, and he was labeled as spastic cerebral palsy. The child had a normal head size, cognition was normal, and there was increased mood and risk reflexes in this particular child. So would you think of something other than cerebral palsy here? Here there is no history of antenatal insult, perinatal insult, the so-called delayed cry. So many times we are just taken away by delayed cry. And if the family says कि बच्चा देर में रोया था, so we put it as birth asphyxia, which is not equivalent. As pediatricians, you all know. So you have to ask about the course, what happened, NICU stay, encephalopathy, seizures, poor feeding, ventilation. That correlates, right? So in the previous SIB also, the correlates were not there, but he was being followed up as a case of cerebral palsy, and he died at 4 years of age. So any guesses here? Leukodystrophy, right? Very good. So what leukodystrophy you will think of? So metachromatic leukodystrophy would be a good possibility here, because they usually begin with motor regression, and later on they can have CNS involvement also. So actually this child was a case of metachromatic leukodystrophy. So clues here are, one is that the child was normal till 1 year of age. If it was something like cerebral palsy, you will have motor delay or even global delay, which will be there since beginning. The second important clue was a family history. So at times we get referrals, familial cerebral palsy. So then a bell should ring that cerebral palsy is not familial. You have to find a genetic cause, right? And a normal head size. In most of the situations with HIE sequelae, you will have a small head size. So these are the clues here where you need to suspect of a neurodegeneration. Okay. Right, so this is, I have just tried to put all the causes of neuroregression, which you may say in pediatric practice. So beginning from, say, hydrocephalus, post-infectious, post-traumatic, hypoxic, which can be perinatal or even later, toxins, nutritional, and even a regression can be there in pervasive developmental disorders like autism. Parents would most of the time say that after 1 year, they notice feature. Initially, they felt the child is normal. Even Rett syndrome, where initially there is a period of normality. Neuropsychiatric disorders, other neurodegenerative disorders which are actually genetic, and importantly, epilepsies with neurodevelopmental regression. There is a large group of epilepsies which is genetic, and if the seizure control is poor, in that situation, the child may regress or the development becomes static, stagnation of the milestone. So these may all be confused with a genetic cause of neuroregression. So it's a very large heterogeneous group. There are many disorders, very difficult to remember all and make a clinical diagnosis even after doing an MRI. So you need to have a broad kind of concept and a broad classification that in which group this particular child may fall in. So this is caused by the biochemical defect at some level. Most of these are autosomal recessive in origin, but you have others like mitochondrial autosomal dominant also. And another thing which we need to remember is that it is not necessary that you always will have a period of normalcy. You may have a period where there was some delay, attainment of some milestones, and after that there will be regression, right? So developmental delay with regression can also be a presentation, and developmentally normalcy with regression can also be a presentation. And we also need to
extra है first number के लिए.
So we need to remember that the regression is global or it is selective, and that's how we usually try to classify whether it's a gray matter degeneration or a white matter degeneration, though the classification is arbitrary. So because it's the phenotypes are very overlapping, the diagnosis is very challenging. At times you may just reach to a conclusion that this looks like white matter neurodegenerative disorder, nothing beyond that. And in late stages, because even the white matter diseases would have involvement of gray matter, at the end of the day, you may just say it looks like a neurodegenerative disorder. In the end stages of the disease, it becomes difficult. And again, to find out, at times the parents would not be able to tell you whether the child was normal initially or no. So they may not give you a correct history. And then based on that, we need some investigations, particularly neuroimaging, which might give you a clue, followed by other investigations, which we will be discussing. So people have been working out on the classification of neurodegenerative disorders, and classically and even still, for clinical purposes, we still classify into the gray matter and white matter, or a combined kind of involvement. And ideally, the classification should be based on whether it is involvement is cortical, whether it is subcortical, and then based on, as gradually we are learning about the genes and the networking, ultimately the classification would probably be something like based on the pathways in which they are there, and that would probably be more informative. So this was a new classification, which is, I don't think it is followed, but then this was put in by a very famous person, Vandenap, who has done a lot of work on leukodystrophy. So here, what they did was that they have even included the neuromuscular disorders in the neurodegenerative group, because in that also you have gradual neurodegeneration. So they try to divide, in addition to the white matter, gray matter, they also divide it into the basal ganglia, where you have extrapyramidal involvement, and there's a large number of disorders there. Then brainstem and cerebellum. So you may have initial features which are looking like cerebellar involvement. So they divided into cerebellar, and then they, as I said, they also included the neuromuscular group and the dystrophinopathies and myotonic dystrophies, etc. in this group. So this seems to be a more logical kind of classification, and probably would be easier to dissect that gray matter versus white matter classification further. So this was one, it has been suggested, but not universally followed. So grossly, what we have been learning, and we still use that in the clinical practice, is white matter versus gray matter disorders. And this is sort of not universally true, that usually the white matter diseases would present slightly late. You can have very early onset white matter disease also. The head size, they may have large head, but many white matter diseases have a normal sized head. At times they can even have a small head. And in gray matter, if it is there, those microcephaly may be there. And then seizures would be a common manifestation in gray matter. Cognitive abnormalities could be an important feature in gray matter diseases. And then in white matter diseases, motor symptoms will more be there. You will have manifestations of peripheral neuropathy later on, involvement of the eye and VEPs and ABRs. So these are sort of some investigations which we do in routine practice, and try to classify these babies into gray matter and white matter based on the phenotype, and then some investigations which we have done to initially screen the pregnancy. And as I said, if the case is quite advanced, it is very difficult to actually classify whether it's a gray matter disease or a white matter disease. So one important thing which I said initially also, how to differentiate it from HIE, because when we did not have many investigations available, it was like a big bag of cerebral palsy patients, every patient who has got some neuroregression or spasticity and microcephaly, they were all labeled as HIE sequelae or cerebral palsy. So, as I said, history of neuroregression will not be there in cerebral palsy. It will be static. They may gain some milestones with the supportive therapy. Family history of a similar neurological sign should really alert you that we have to think of something other than cerebral palsy. Sibling death, consanguinity, family history, head size to some extent, as I told you. And though we are labeling it as birth asphyxia, but when you dig into the history, there's actually no asphyxia documented. So that really, and then if you have a normal neuroimaging, right? Usually, if there's a severe asphyxia, you will have abnormality in neuroimaging. So there are certain inborn errors of metabolism, particularly small molecule diseases, which can present as HIE mimics. And Dr. Neerja will be taking a presentation tomorrow on small molecule approach to IAIMS and cases. So I'm sure she will be having one of the cases there on HIE mimics also. So as I've already listed in that figure, these are the usual causes which come with neurodegenerative disorder, neurodegenerative presentation, and we really need to classify them and actually see what are actually the genetic causes of neuroregression. This is a girl with Rett syndrome, where in typical Rett syndrome, if you do a good clinical diagnosis, the field of molecular studies is almost 100%. So acquired microcephaly, neuroregression, that typical hand stereotypies, and labored breathing, which they have in between. There are certain criteria based on which you clinically can classify and make a clinical diagnosis of Rett syndrome before doing a molecular testing. So history, as I've already told you, antenatal, perinatal history of jaundice. So many times, because of post-connectorous sequelae, these patients will come to us with hearing problems and extrapyramidal manifestations. And many times they come with the exomes, and they have many other investigations. And in the exome, you have a variant which tells us that the child was G6PD deficient, and because of that, he had neonatal hyperbilirubinemia and sequelae. Actually, it was a sequelae of hyperbilirubinemia, right? At what time the disease presented, and what are the nature of neurological manifestations? As I told you, whether it is primarily looking like motor, or it is looking like cognitive, or it is looking extrapyramidal or cerebellar, and based on that, you can try and find out what could be the etiology. Examination gives you many clues, but not in all cases, because in most of these situations, you will not pick it up by dysmorphology, except in few neurodegenerative disorders where you have dysmorphic features also. Head size is a very good clue, and you can have, you can suspect a specific diagnosis. We will see that. And hair changes may be seen in biotinidase deficiency. They may have very sparse hair, right? And in something like Menkes kinky hair disease, hair microscopic, and even clinical examination can give you clues. And then Mongolian spots, pigmentary changes in the skin, angiokeratomas, all these can give you idea. And obviously, eye examination is a very, very, very important. So any child with neurodegeneration, you have to get an eye evaluation done, a good eye evaluation with fundus examination, hearing involvement, organomegaly, hernia, all these would give you, and cardiac and joint involvement. You know, I am pointing towards the group of mucopolysaccharidosis, particularly the severe form, severe spectrum like MPS 2 or MPS 3, which is MPS 3 is at times missed because they do not have the classical telltale phenotype of LSD in most situations. Okay, so these are some of the pictures which are familiar to you. So you just see the phenotypic diversity even in the lysosomal storage disorders like MPS. So you can, at first go, you will not say that this child has got MPS 1, right? But this child is a case of MPS 1. This is a child with MPS 3, and that's why I was telling you, because they do not have other manifestations, just very severe behavioral problems and neuroregression, hirsutism, organomegaly may or may not be there. You definitely need to think in terms of MPS 3. It is quite common, probably it is more common than diagnosed because it is missed clinically and we do not investigate. This is also a child with MPS 1, milder phenotype. This child I showed, this is Zellweger syndrome, and these are the kinds of skin.
There's somewhere written that they have this type of light color. I have seen in many MPS 1.
No, and even we have seen here MPS 2 patients also I have seen that they have light colored hair.
Brownish golden type case.
है कुछ बच्चों में हमारे पास भी है हाँ इसका भी है and these Mongolian spots and this gibbous which is typically seen in GM1 gangliosidosis and severe forms of MPS 1 also. This is a child with a large head size and seizures and neuroregression. So what will you think of? Or flus, startle, excessive startle. So Tay-Sachs, Tay-Sachs disease, right? And these are some other patients of mucopolysaccharidosis. And then you have the KF ring, you have telangiectasia, and this is a child which is typically having these eye signs and organomegaly along with some neuroregression, this splenomegaly. So what will you think of? Organomegaly, anemia and thrombocytopenia, and this kind of eye abnormality. Sorry? Osteopetrosis. Yes, in the sense that they can have organomegaly, severe anemia, and they can have eye problems because of optic atrophy. But this child has Gaucher disease type 3. I'll be showing you later. So this is, and then corneal clouding, which we commonly see in MPS. So can anybody think of a diagnosis here? This child had microcephaly, neuroregression, has this photosensitivity, and on neuroimaging had calcification in the basal ganglia. Is there any other relation? Cocaine syndrome. Cocaine syndrome, right? And this child is Menkes kinky hair disease. So the very classical Fine-Viscer X-linked disorder, the very classical phenotype is like what you are seeing here. So when you see the parents and you see the child looks blonde as compared to the parents. He looks as if the face is slightly expressionless. And the hair are as if some gel has been put on the hair. Like straight type, very abnormal hair. And the diagnosis can be confirmed by doing a routine hair microscope. Right? So here you can see this we call as pili torti, and there are many other signs which we see under the microscope where the diagnosis can be confirmed later on by doing now molecular studies, otherwise earlier copper, celluloplasmin and all those things. Okay, and this is a very typical phenotype of abnormal fat distribution. We discussed a case of CDG which was not as typical, but there are many types of CDG, and this one type of CDG, they have this very abnormal fat distribution and these inverted nipples, which can in fact clinch the diagnosis almost immediately. So I was talking to you about Gaucher disease, and I'll be showing you a few slides on this because this seems to be probably the commonest lysosomal storage disorder which we see in India, and the neuronopathic type is more common. You know, there are 3 types of Gaucher disease. Type 1 Gaucher, which does not have neurological manifestations. Type 2 Gaucher, which is very severe neurological manifestations and they would die early. And type 3, neurological manifestations, which may vary from mild to severe, and organomegaly with pancytopenia and other manifestations of Gaucher. So we seem to have more of type 3 Gaucher and a mutation, which is a common mutation which we see in India, which is L444P. Okay, so these babies can have all these kind of neurological manifestations, which vary from dementia, ataxia, regression, in severe form, stridor, swallowing difficulty, opistotonic posturing, and eye abnormality, and what we call as oculomotor apraxia. I'll be showing that. Squint they can present with, abnormal eye movements they can present with, and they can, in severe forms, they can have seizures, particularly myoclonic. So they can present like progressive myoclonic epilepsy. This is one of the differential diagnoses for progressive myoclonic epilepsy also. So like you see this child, this is a child with type 2 Gaucher disease. You can see a very young child with this retroflexion of the neck, stridor, feeding difficulty and organomegaly. This is another type 3, which is not as severe, but early manifestations, huge splenomegaly. And here you see the same child which I had shown you there, just showing the eyes. So for neuronopathic Gaucher, this is one of the child who is on therapy now. you can see this girl who's so emaciated with this massive organomegaly, and she had severe anemia with multiple platelet and PRBC transfusion. So for the eye signs, apparently, if you look at this child, the eyes appear normal. There are no neurological manifestations. So to look for these abnormal eye movements, that's this.
जब मैं बोलूँगी ना ब्लू को देखो तो फिर आप ब्लू को देखना, ठीक है? और जब बोलूँगी ब्लैक को देखो तो ब्लैक को देखना. ये ब्लैक है, ये ब्लू है, ठीक है? सृष्टि ओके बोलो. ब्लू को देखो. ब्लैक, ब्लू, ब्लैक, ब्लू, ब्लैक, ब्लैक को देखो.
And
ब्लू को
just
देखो.
look with eyes.
ब्लू को
Child
देखो.
moves her head along. And the movement of the eyes is very
बेटा.
So this is
ब्लैक ये है बेटा. नहीं हो रहा है? अच्छा ठीक है, हाथ छोड़ दो. अब देखो. हाँ, अब ब्लू को देखो.
turn her head.
ब्लैक को देखो.
Very
ब्लू को देखो तो फिर आप
look at whenever you have a child with Gaucher. And we have to be very careful because in young children, it may be missed. There's a study which was conducted at our center. Dr. Nija was called, she was a chief guide of the MD student. And when a specific technique was used in physiology, which we used to do for checking eye movement, the cylinder thing and all, for that a sophisticated software is there now to check the eye movements. So a large proportion of cases where we could not make out that the child actually has oculomotor apraxia, it was picked up by that particular device. So we have to be very careful because if these abnormal eye movements are there, then the child is classified as type 3. Okay, there are various types of type 3 also. And if there are no neurological manifestations, that the child is classified as, or patient is classified as type 1 Gaucher disease. Okay, so these are the list of investigations which we may need to do depending on the scenario, starting from blood counts, even ammonia ABG lactate, because some of these patients who are actually small molecule disease can present later also. And the investigations for small molecule disease, GCMS, HPLC, X-rays, MRI, brain, bone marrow, other biopsies, urine MPS test, copper, celloplasmin, enzyme assays, and for plasminogen and VLCAP for peroxisomal disorders. But now, many times, after the initial investigation, our diagnosis is established by doing molecular studies, which could be targeted or which could be based on the exome sequence. Okay, so this is typical finding on X-ray, which you see in mucopolysaccharidosis. So dysostosis multiplex, I think all pediatricians are taught about this even in MD. So when we were doing MD, we were hardly taught about genetic disorders, but this MPS, X-ray findings on MPS, we used to get an X-ray for the exam and for reporting also. So you can see that how different they are. So you have this pointing of the metacarpal bones. Yeah, this is proximal tapering, and there's bulleting, and there is the inferior beaking, and you have this platyscondylian beaking. So, and there are changes in the pelvis also. You have a separate session on MPS and you'll be taught about this. Now, MRI is, I think, one investigation which can give you clue. And some of the pediatric radiologists or pediatric neuroradiologists are so good, like we have one in our institute. He would make a diagnosis on MRI that this is this disorder and nothing else. And 80 or 90% of the times he's correct when we do the enzyme or the molecular studies. So, but then again, in the initial stages of the disease, if the disease is quite advanced, even in the MRI, you may not be able to make a diagnosis. So this is kind of a general pattern of MRI patterns in leukodystrophy, that in MLD and Krabbe's, the demyelination starts from the center to the periphery. And then if you have something like megalencephalic leukoencephalopathy in Kahneman disease, in that you have peripheral to center. Then you have posterior to anterior. This is very classical for adrenoleukodystrophy. Initially, you will have involvement of the occipital and parietal bones. And similarly, some other findings like characteristic cysts in megalencephalic leukoencephalopathy, contrast enhancement in adrenoleukodystrophy, because the pathogenesis involves a lot of inflammatory mechanisms here. So there is enhancement, which you can see here. And it will be useful for deciding about the treatment and progression of disease also. So this MRI really gives you clues. And another technique which is important for white matter diseases and some other gray matter neurodegenerative diseases is MRS, MR spectroscopy. And with this, you can get different kind of peaks based on which you can sort of try and classify whether we can say that if NAA peaks are there, it could be Canavan, or lactate peaks may be seen in mitochondrial disorder, and so on. So some of the diagnosis we can get clue based on the MRS. So in certain situations, if you have a suspicion that it could be, say, Canavan's disease, so in addition to MRI, you will also say that do an MRS also, and we might get a clue for that. Okay, so this is a typical pattern which is seen in the initial stages of this periventricular white matter changes. So MLD, metachromatic leukodystrophy. But as the disease advances, this is called a typical tigroid pattern in MLC. So as the disease advances, it may become more classical as you see in metachromatic leukodystrophy. Now, this is one disease. I was thinking to put a case, but I forgot about it. So neuronal ceroid lipofuscinosis is one neurodegenerative disorder which is said to be the commonest. And there are many variants starting from early infantile, late infantile, adult onset, and the manifestations are very, very different. So the index of suspicion has to be very, very high. And there are multiple genes which are involved, and the presentations might start as early as congenital NCL, but then classically, typical phenotype is seen like infantile onset, where you have neuroregression, microcephaly, and myoclonic seizures, and you may have visual problems also. That's a classical manifestation, but the others could be very, very variable presentations. So you really need to keep a very high index of suspicion. And there are earlier some tests like biopsies and things were done to look for specific inclusions and all, but now most of it is based on the molecular studies, and neuroimaging might give you some clue, particularly if there is involvement of cerebellum, as you can see here, and overall atrophy ultimately. And earlier, some inclusions were also seen under the electron microscope to sort of find out whether there's a particular type of NCL or no. But now it is not being done unless you want to prove a particular variant, which is variation of unknown significance, and you want to go back and sort of do kind of a functional studies to prove that it is NCL. So another very, very heterogeneous group of disorder is the mitochondrial disorder. So when we are not able to classify, or we are not able to put a diagnosis anywhere, and there are multiple manifestations, you have cognitive also, you have neuromuscular also, you have liver also, and eye also. These are all dumped into probable mitochondrial disorder because these are multi-system involvement, right? So it can involve eye, nervous system, heart, liver, kidneys, skeletal muscle, digestive tract, anywhere these can be. So if there is a neurological involvement along with multi-system involvement, mitochondrial disorders have to be kept in mind. Okay. So then you can see the type of mitochondrial disorders. The phenotypes may be very, very overlapping. Specific phenotypes are few, which can be picked up, right? But then otherwise, you may have, even the MRI findings are very non-specific and may be found in more than one mitochondrial disorder. So in these situations where we are not able to classify, the MRI findings are not telltale. So in that situation, we need to work for mitochondrial disorders also. So now we will have some representative cases, and I'll try and find out if you can get some clues for diagnosis. So now this is one case, 10-month-old girl, global developmental delay with excessive irritability and neuroregression, microcephaly, and the parents would say that the child intermittently becomes like this. What else you would like to ask? Okay, start with. So, birth asphyxia, there is no history. No history. So first tell me what you are thinking of. Is it a white matter disease or a gray matter disease? White matter. Why white matter? Early onset. So gray matters are usually early onset, right? So here there is developmental delay also, and irritability is one finding which should sort of ring a bell in white matter degeneration. Krabbe's. So Krabbe's disease, the classical infantile type, would present like this. Child will be very irritable. When you examine, the findings would be more of white matter involvement. The important thing which you need to check and look is the visual problems, because these children would develop optic atrophy, right? And they can, if they survive later on, they can have some features of peripheral neuropathy also that might develop later. So this was suspected to have Krabbe's disease, and this was the MRI of the child. It was showing periventricular changes, white matter changes. And these are the classical findings which progressively happen in Krabbe's disease. You can see these periventricular changes for white matter. And this child actually had a deficient galactocerebrosidase enzyme. And there's a common 30 kb deletion, which is commonly found in Krabbe. So if you make a diagnosis of Krabbe, you first do a targeted test for that particular mutation. And then if negative, you can do either the gene sequencing or you can do a exome sequence. Okay. Now this is another child. I think it should be a spot diagnosis. So one male has died. This is another male child. This is the MRI. नीचे लिखा भी हुआ है diagnosis. So X-linked adrenoleukodystrophy was a diagnosis in this particular child. And this is a very classical MRI of involvement of the posterior part of the brain. And very importantly, it would enhance after you give the dye because of the inflammatory process which is going on. Sorry, it shows active inflammation. And because of the involvement of the endocrine system, these children would often be hyperpigmented. Okay. And many times you have the Addison's only phenotype. Based on what kind of mutation, there is a very severe phenotypic diversity in adrenoleukodystrophy. You know, there is a cerebral form, then you have adrenomyeloneuropathy, and you have Addison's only form also. So the Addison's only form, many times these patients are being treated in endocrinology as a case of Addison's disease, and they develop some behavioral issues or difficulty in walking, and then they are sent to us. And ultimately, we find that these are actually cases of adrenoleukodystrophy, right? So you have to keep these 2-3 clues in mind when you're suspecting that it could be ALD. So this X-linked ALD, as I told you, has a typical MRI finding. Classically, the diagnosis is done by, it's a peroxisomal disorder. So very long chain fatty acid levels are done. And in MRS, you may get some clues. And you can see here that in about 70% of cases, there is adrenal dysfunction. So even if there is no hyperpigmentation or other manifestations of Addison's disease, in all these patients, you have to do cortisol levels. And if they are low, they have to be supplemented with steroids. And nowadays, because testing VLCFA, there are only 1 or 2 labs in the country who do it, and it's very expensive. Most of the time, we end up doing direct molecular studies to make a diagnosis of ALD. Okay, now this is another neurodegenerative disorder, which we should all know. Okay, so this is megalencephalic leukoencephalopathy, right? So here, these patients may be born or may be noticed to have a large head in infancy. Okay, and very slowly progressive disorder. They may have some spasticity, ataxia, and very, very gradual progression to neuroregression. The classical findings, apart from white matter changes, are these subcortical temporal cysts. This gives you a clue. And importantly, this is commonly seen in Agarwal community. Okay, so there is a founder mutation here, which is seen in almost 100% of patients with ALD if they are originating from Agarwal community. So here, the targeted test is doing this particular mutation first. If it is negative, then you go further. So based on the clinical examination, you get clues, and then you do the investigation accordingly. Okay, so I have put in some adult cases also here. I'm not sure how many of you are adult clinicians, but now with increasing awareness, we are getting a lot of referrals from our adult neurology and medicine colleagues, and very interesting diagnoses are being made. So now this particular family was referred to us. This was a 50-year-old male who presented with insidious onset progressive weakness of the lower limbs and bladder disturbances for 9 years. Along with that, there were aggression, behavioral issues, and otherwise no other cause could be found, and there was no family history which was positive. So this was the kind of pedigree which we drew, And we found that there were multiple individuals affected in the family with a similar disease. So what inheritance it looks like? So how many of you say it is autosomal dominant? Only one. Yeah, so this looks like autosomal dominant. Basically, and there was the detailed neurological examination which showed that there is white matter involvement, and they did a lot of studies, including SCA studies and all. It was all normal, and they referred the patient to us saying that please rule out adrenoleukodystrophy. So, do you agree it could be adrenoleukodystrophy? That's an X-linked disorder, and the pedigree clearly tells you that this is autosomal dominant. So finally, we thought that this is some kind of a autosomal dominant leukodystrophy, white matter disease, right? So we were, and there is an entity called autosomal dominant leukodystrophy, and we were sort of about to get a NGS done. But I think it is a dictum. This is a rare disease. So if you do not know much about the disease before ordering NGS, it is better to look at it, right? And when we looked at it, and these are some MRI findings which they sent to us, which had some white matter abnormalities and even the involvement of the pod. So these were the findings. So when we read up about this, this is actually caused by a duplication in a particular region of chromosome 5. And at that time, the NGS reports were not reporting copy number variations. Now they are reporting copy number variations also. So if we would have done exome sequencing, we would have missed it. But because we read up and we found no, the choice of investigation is chromosomal microarray here. And with chromosomal microarray, this duplication was picked up and the diagnosis was proven. And this is autosomal dominant leukodystrophy, which is a well-known entity, and the diagnosis could be made. So this was a microduplication found, and adult onset autosomal dominant leukodystrophy diagnosis was confirmed here. So another case, this 12-year-old girl presented with scaly skin rash all over the body, like ichthyosis, developmental delay, intellectual disability, again spasticity, historically no visual hearing problems, fundus. Probably there was some foveal thickening, no organomegaly, and hypertonia and wrist reflexes. And this was the girl. You can see this severe ichthyotic changes along with spasticity, which is evident here. Any clues? Yes. So this was a case of Sjogren-Larsen syndrome. And again, you can see the changes in the white matter, which you can see very clearly here. And then here MRS also helps, which is almost like pathognomonic. So you get abnormal peaks at a certain region, which is quite typical. And this is because of the accumulation of lipids such as fatty aldehydes and fatty alcohols. So this was a case of Sjogren-Larsen syndrome, and molecular confirmation was sent. I forgot to check, but then probably this was molecularly confirmed also. So here, very, very typical phenotype, the skin changes. So you have to look at the other changes which are there other than the neurological examination to find out whether it can give you a clue for diagnosis. Okay, so these are 3 examples of a mitochondrial disorder with abnormality in a mitochondrial gene called NUFB1, and same mutation was identified in 3 families, which typically presents as Leigh syndrome, but you can see here the phenotypic diversity here. One child presents as early as 10 months of age with such severe manifestations. Another child presents at 4 years of age with different kind of manifestations. And then another child actually presents at 8 years of age with fever trigger seizures and extrapyramidal manifestations. So we really need to keep this in mind, that the genotype-phenotype correlation may not be true in many situations, particularly in neurodegenerative disorders. This is also true for adrenoleukodystrophy also. In the same family, you can have different phenotypes, a cerebral phenotype or a adenomyeloneuropathic phenotype. So just to show that with the same variation, you can have different phenotypes. The mechanisms for that is not actually known. It may be beyond these simple molecular studies, because there are many other things like epigenetic abnormalities and all, which might modify the phenotype or other modifying genes which may be there. So these are the MRI findings of these patients, and you can see the severity of the MRI changes is so high in the case 1 as compared to the other cases. Okay, so another case which was again referred from our adult neurology colleagues, 29-year-old male presented with gait disturbances, cognitive decline, behavioral changes, and decreased interaction. And in examination, there was abnormality in impaired, the frontal lobe signs were there. And importantly, an important sign which we picked up was a vertical supranuclear gaze palsy and dysarthria. So does this give you any clue? So this is vertical supranuclear gaze palsy. And if you have got a vertical stagmus, like as I showed you, the oculomotor apraxia, if you do a similar test in these patients, they will have a horizontal gaze would be okay. But if you see the vertical gaze, you will find that there's a stagmus and the gaze palsy in the when you do the vertical movements. So this is a very important sign of Niemann-Pick disease type C. Okay, they may or may not have organomegaly, right? They would not have hematological involvement. They would primarily present with neuroregression. They can have myoclonic seizures and they can have these abnormal eye movements. And these were the non-specific findings on the MRI, where they just showed that there was some atrophy and some white matter changes, nothing pathognomonic about it. And then on exome sequencing, there was a homozygous change which was found in MPC2 gene. And hence the diagnosis was confirmed. There is some role of substrate reduction therapy in NPC. Miglustat is a drug which is being tried, but in fact, in early stages of the disease, probably it helps also. But again, it is exorbitantly expensive and difficult to use in our setting. So another case, this 5-year-old girl, predominant motor developmental delay, and then frequent falls, behavioral problems, excessive crying, fighting, excessive drooling, intermittent dystonias, vision impairment, but there was no episode of encephalopathy in a child who was similarly affected. And again, on examination, other than intermittent dystonia, there was nothing specific. Okay, so here we did not have many clues on clinical examination, but then the workup showed so almost normal. In eye findings, there were bilateral pigmentary changes. There were some changes on electroretinogram, but MRI brain actually gave us a classical finding which clinched the diagnosis that I'll be showing that, which showed some mineral deposition in the globus pallidus. And on exome sequencing, it was actually a variation in PANC2 gene, which caused these iron depositions because of the abnormality in the iron metabolism. So this is the typical finding because of the mineral deposition in the globus pallidus. And does anybody know what this sign is called? Eye of the tiger. So this is like eye of the tiger sign, which is almost pathognomonic of this classical PCAN, or this is PANC2 gene mutation, right? So the phenotype again is very, very variable in this particular disease, but here MRI usually helps. MRI clinches the diagnosis in most of the situations. Okay, so another child, global developmental delay. Later on, there was some regression of milestones and behavioral abnormalities. And he was a 10-year-old boy, mild coarseness of faces, as we will see. And we also noticed that there were some angiokeratomas, there was consanguinity, and you can see 3 sibs are affected here, and spasticity and reflexes. And this was a child, irritability, some coarseness. These are the angiokeratomas. You can see multiple angiokeratomas here. So what are the causes of angiokeratomas? And neurofibromatosis, you do not have angiokeratomas. Any other diseases? So these are angiokeratomas. The causes are these. Apart from Fabry would be the commonest. Fucosidosis, galactosialidosis. There's one disease called Kanzaki disease. I have never seen this. Beta manosidosis and glucosaminoreduction. So these are the causes which should be thought of as soon as you have angiokeratomas, right? So here he was not looking like Fabry's disease, and we thought in terms of some other storage disorder, which could be Fuco, Galacto. There was no cherry red spot here, though beta monocytosis or the other one. So, and this was the mild, these were the features on the X-rays. You can see that there is features of dysostosis multiplex again. Can you appreciate that? Even changes in the pelvis are there, and you can see that there is beaking and platyspondyly here. So, and then there are MRI changes where you can see there are some signal changes in the globus pallidi again, which was going in favor of fucosidosis. And these are some differentials which can be looked for on MRI findings to differentiate between other causes which causes angiokeratomas, and MRI might give you some clues. So particularly in fucosidosis, you can have these particular findings which might give you an idea that this could be fucosidosis. And the enzyme for fucosidosis came deficient here. And I don't think molecular studies were done for this particular family or not, but then this was confirmed by enzyme assay. No treatment as of now for fucosidosis, but the phenotype is, typical in the sense that with angiokeratomas, if you have coarseness of facies and this kind of MRI findings, you need to think in terms of fucosidosis. Okay, this is another child who was a 3-year-old boy, I think from Nepal. Antenatally, there was some mild dilatation of left ventricle in the level 2 scan. There were no problems, initial normal development, but later on there was impaired hearing and myopia, and then no history of seizures, and the parents thought that probably there is some developmental, now the development is static, initial normal development was there, and there was no family history. So this was the child, the anthropometry almost normal, again some coarseness of facies, clear cornea, kyphoscoliosis, and there was hepatomegaly, and CNS had hyperreflexia, but there was a cherry red spot here. On examination, there was hepatomegaly, again dysostosis multiplex. We did multiple enzymes like for lipidosis, we did serum enzymes, we did enzymes for fucosidosis, monocytosis, MPS2, urine oligosaccharide screen was though positive and suggestive of sialidosis. And then on molecular studies, actually it turned out to be sialidosis. So here, an important clue is the cherry red spot in the macula, and with findings which are suggestive of storage and coarseness of facies and organomegaly. And this was a child of sialidosis. Okay, so these were some of the cases which I wanted to show you, and because the time was not there and you have multiple sessions on therapies, I am not going in the details of therapies. I have just sort of put them here that what can be done. Like rabies, there is no specific treatment. Very, very early pickup, say by newborn screening or something, HSCT may help. For metachromatic leukodystrophy, HSCT was being tried, but now I think you may be knowing there is an effective gene therapy available for metachromatic leukodystrophy if they are picked up early. And then for adrenoleukodystrophy, HSCT, gene therapy, both are there. You know, for lysosomal storage disorder, enzyme replacement therapy, HSCT are there. And then for mitochondrial and other disorders, there are like cocktails of vitamins and things. Specific diseases like Wilson's, you know, can all be treated. So I'll not go in the details of this, but just show you one case of bone marrow transplantation, which was done in a child at our center with X-linked adrenoleukodystrophy. So we have a bone marrow transplant board where from people from clinical genetics, from neurology, and our oncology team who actually does the transplant. And we put in cases there of, say, things like leukodystrophy or some of the lysosomal storage disorders, primary immunodeficiencies, and others. And then we decide whether transplant is going to help this particular child or no. So now this child actually presented to the neurology division at 9 years of age. And he had an episode of acute febrile encephalopathy that resolved, but there was some hyperpigmentation which was noticed. And when the child was, and there was history of focal seizures, and later on, the parents noticed that there were some subtle behavioral abnormalities. They did a lot of neurological examination, various scores for cognitive development and all, and this was done. There was some mild spasticity, which was also there, and this was a child. You can see the hyperpigmentation here, and you can also see the area from which he's coming. He's from a very, very deprived area. Community also, they were not well off at all. And after this, MRI was done, which is very classical of adrenoleukodystrophy here. You can clearly see this. And before we do a bone marrow transplantation in ALD, there is a score which is called lowest score, which is done on MRI, and a score cutoff is taken as 9. If the score is more than 9, then HSCT is usually not that much helpful. But in this family, the child's MRI findings were sort of discordant with the neurological examination, and the parents were very insistent that if something can be done for this child, please do. So because for bone marrow transplantation, money is available through the RD policy and also from other schemes. So then, and this was without enhancement, you can see this. So then molecular confirmation was done, and the donor was a sister who was not a carrier. So the recommendation for HSCT is that preferably you should not take carrier donors. If no one is available, now carrier donors can also be used. So for ALD, if it's a female, you would always rule out the carrier status, but it was a full match. And after discussion and explaining the family, bone marrow transplantation was done, and there was a regimen which has been now finalized and being used for ALD patients. And you see the follow-up at 6 months, 12 months, and now even more. So this was about 2.5 year follow-up. So seizures got controlled. Behavioral issues were there initially. The scores remain almost static. And then even at 12 months, the findings were almost similar. And the MRI score, the lowest score on MRI remained static. Okay, but there was no gadolinium enhancement, which was there initially, indicating that the inflammatory process is resolving or has stopped. And at 2.5 years, you can see that the behavioral problems have also gone. The scoring which they done initially has come down. And when the MRI was done, you can see later on, you can see the MRI which was there earlier and later on, which shows improvement in the MRI. So now this child is static, in fact, some improvement in the behavioral abnormalities also, and is doing well. So this risk was taken, though we know that the outcome may not be as good, but the family insisted, and at the back of our mind, we thought that the neurological manifestations are not as bad and we should try and do it. So this child was helped by doing the bone marrow transplantation. So to end, counseling is extremely important about the course and prognosis, and now specific therapy because it is available, but it is extremely expensive, right? So availability is still an issue. Risk of recurrence, prevention, course, prognosis, treatment, and very importantly, for preventing birth of further children, prenatal testing can be offered to these children. So the take-home messages here are that degenerative brain diseases or neurodegenerative disorders are very heterogeneous, complex groups, overlapping phenotypes. There may be very good clues in history and examination. Neuroimaging gives you good clues, and neurodiagnostic modalities, I would say here that at times, instead of doing conventional things, we may directly do NGS-based testing, but not for disorders like mucopolysaccharidosis and things like that, where we would first do the enzyme assays and then do the molecular studies. Confirmation of diagnosis is important, not only for counseling and prognosis, but also for treatment now and prenatal diagnosis. So all efforts should be made to have a specific diagnosis and management of the patient. Thank you very much.